Welcome to this new session of Transplant International Podcast.
Hello, everyone, and welcome back to the Transplant International Podcast, where we explore the scientific advances and clinical innovations shaping the future of transplantation. I am Nina Pilat. I'm Deputy Editor-in-Chief of Transplant International and your host for today's June episode. My co-host today is Editorial Fellow Antonio Citro, and he will help guide us through the papers we selected for this month. Today we are covering 3 papers that in very different ways are all pushing transplantation towards more precision before, during, and also after the transplant itself. The areas covered today are sex differences in PET-based risk assessment before liver transplant, the antibody quality in kidney rejection, and the last paper is dealing with a new cell therapy strategy using CD8 regulatory T cells.
Thank you, Nina. What I like about putting these 3 manuscripts together is that they all challenge a simplification. We're comfortable with a tumor volume cutoff, a positive or negative antibody test, a single class of regulatory cells. Actually, each paper says it's more nuanced than that.
Everything going towards precision. So already looking forward to dive in. For our new listeners, our goal is not to replace the papers, but to give you a concise and critical overview that makes you want to dive into the full articles, look at the figures and methodological details, and also think about how these findings may intersect with your own practice or research. And before we begin, as always, a brief reminder, the views expressed in this podcast, they are our own and they do not necessarily reflect those of Transplant International or Resort. So let's start with the paper authored by Stern and colleagues, a Norwegian transplant center. The topic is liver transplantation for colorectal liver metastases. This paper is also featured on the cover of our June issue. So, Antonio, can you tell us why is this paper so important?
Thank you, Nina. So, liver transplant for non-resectable colorectal metastases actually is a real but resource-limited option. So selection matters enormously. Metabolic tumor volume from FDG, PET, or CT, essentially how much metabolically active tumor our patient is carrying, and has already emerged as a strong predictor of outcomes. So that's why it's really important. So this study asks whether the predictive power looks the same in men, actually in women. And the answer is no, it doesn't.
Okay, so that's a really important question and also an interesting answer. So what did they actually see? Why doesn't it look the same?
Yeah, so in the paper, in patients with a low tumor burden, men and women did broadly the same. But once the tumor burden was high, women fared distinctly worse than men, shorter survival overall, and a much higher rate of recurrence outside the lung, which tends to be harder to control than lung-only relapse. So high tumor volume isn't just bad in general, it appears to hit women harder.
And do we have any idea why, or what did the authors tell in their paper?
That's a very good point. Not really. So the paper is honest about that. Hormonal biology, immune differences, fat distribution, tumor behavior are all plausible. None are proven here. This is a small single-center retrospective cohort, so it's a signal worth watching, not really a mechanism behind it.
Okay, and does this change then who gets listed for transplant if there is a difference in outcome?
Actually, not yet. And the authors are clear about that too. So they look at whether separate cutoff for men and women would help, and to conclude that the current share threshold still holds up reasonably well. The practical message is softer. Sex is one of more pieces of the contest to weight when a woman presents with a high tumor burden, a prompt for a closer multidisciplinary discussion, not a new rule. It's need validation, of course, in bigger multi-center cohorts before it becomes a really practical activity, no?
Mm-hmm. And zooming out for a second, why does a finding like this matter beyond this one small cohort?
Because it plugs into something bigger happening across oncology. Sex is often treated as a background demographic detail rather than a biological variable. This is normally actually in other papers. And yet across many cancers, we're increasingly seeing that tumor behavior, immune surveillance, and treatment response don't necessarily play out the same way in men and women. So liver transplant for metastatic disease is a small field, but it's exactly the kind of resource-constrained, high-stakes setting where getting risk stratification right matters most. Every graft allocated is graft someone else doesn't get.
Yeah, that's right. And so even a modest single-central signal here deserves real attention.
Exactly. It's a sort of prompt for the field, routinely ask whether an established risk marker actually behaves the same way across sexes, rather than assuming one cutoff fits everyone equally. So that habit of checking is arguably as important as the specific results.
Does this connect to other work you've seen, or is this like a one-time only finding?
It does briefly. A separate multicenter study has already flagged female sex as an independent predictor, actually, of worse outcome after liver transplant for colorectal metastases, without tumor volume in the picture at all. So this paper adds a next layer to the story. It suggests that sex may specifically interact with how much disease burden a patient is carrying, rather than acting entirely on its own. So two independent groups covering on a related signal from different angles is worth taking seriously, even while the underlying mechanism remain open in the discussion.
So thank you. And to our listeners, dive into the full paper. It's really interesting. Our second paper moves into kidney transplant and antibody-mediated rejection. Noble and colleagues with the great title, Not All Antibodies Are Created Equal. What's the puzzle they are addressing here?
Yeah, so we usually treat donor-specific antibody as a sort of yes or no risk factor. But plenty of patients with DSA never develop severe rejection, and some without detectable DSA still do. That mismatch suggests antibody presence alone isn't the full story. Maybe antibody quality matters as much as antibody quantity. And here, quality means glycosylation, the sugar structure that is attached to the IgG, which shape how an antibody engages complementary immune effector cells.
So in the specific study here, what did they find in their transplant recipients?
So using a simple lab test, a lectin-based ELISA on total IgG from patient with active rejection, chronic active rejection, and no rejection, one glycal feature stood out clearly. Bisecting ZLAC and NAC, I try to pronounce correctly, it tracked with both the severity of active injury and chronic scarring in the kidney, and the disease interesting twice. It did so largely independent of whether donor-specific antibody were present or not.
That's really interesting, like challenging paradigm in transplantation. So independent of DSA, what does that mean in clinical practice?
It hints the concept of the glycosylation might be picking up a pathogenic signal that our current DSA testing misses entirely, maybe from non-HLA antibodies or more general inflammatory antibody states. The authors frame DSA and glycosylation as two separately, possibly competing injury pathway rather than one simply expanding the other.
That's really amazing. Could this become like a new clinical test to test for like the bad antibodies, not just antibodies at all?
That's a good point. So the assay itself is attractively simple and scalable. This is an important part of the story, which is appealing indeed. But this is under 80 patients using total IgG rather than antibody purified specifically against the donor. So it's a proof of concept rather than an established model. So not really made biomarker. It needs replication and needs to show it at something beyond what biopsies and standard DSA testing already tell us.
Okay. So the headline isn't start testing glycosylation on Monday, but it's like antibody presence isn't the full picture here.
Exactly. So it's conceptual shift as much as technical one. So from asking whether an antibody is there to asking what that antibody is actually capable of doing.
And how does it fit into the bigger picture of transplant diagnostics?
Yeah, that's a good point. It's a part of a broader shift towards looking past whether an antibody is present towards what the antibody actually does functionally. We have landed heavily on tighter and specificity for years, but that framework has known a blind spot. Patients with antibodies will never reject, and rejection without any detectable antibody. So glycosylation is one of the several post-translational features the field is starting to explore to close the gap. And it echoes works already underway in autoimmune disease, whether glycal pattern, track disease, activity, and treatment response.
Okay, so does it change how we think about the biopsy-based scoring system we already rely on? Do we go towards like quality over quantity in terms of antibodies?
Yeah, it's another good point. So not replace them, but potentially complement them. So histology through the Banff classification remains the anchor for diagnosing rejection, and that isn't going anywhere. But molecular and functional layers like these are increasingly proposed as companions of that framework, a blood-based signal that could, in principle, flag the risk earlier or less invasively, easing some reliance on repeat biopsies. That's a mindful direction for the field, even though this particular assay still has a long road in terms of validation ahead.
Thank you. So really important. And our third piece today is a commentary by Mulan Zuber on CD8 regulatory T-cell therapy. This is more forward-looking. What's the context? I mean, everybody knows CD8, CD4 regulatory T cells, but now we have also CD8 regulatory T cell therapy.
Yeah, so the long-term goal in transplant immunology isn't more immunosuppression, it's smarter, more targeted immune control. This is always like the new era in the new regulation. So regulatory T cells are the field's leading candidate for that. And so far, almost all the clinical momentum has been around CD4 Tregs, as you mentioned, with dozens of trials underway. This commentary actually spotlight something newer. So the first in human 8 Treg trial testing CD8 regulatory T cells in kidney transplant recipient. So it's important to be clear, this is a phase 1 safety and feasibility study, not an efficacy readout.
Yeah. That's for sure. I mean, we had so much trials with CD4 regulatory T cells, and most of them have been safety and feasibility trials. So those CD8 Tregs specifically, when the CD4 Tregs already have a head start, so many trials completed and underway, and we still don't know what to do with them exactly. Why now the CD8s? What can they do?
It comes down to what these cells can see, really. No? So CD8 Tregs recognize antigen presenting through HLA class 1, which is expressed everywhere, including directly on the graft tissue. So conceptually, they could patrol and act right inside the organ itself. CD4 Tregs instead work mainly through HLA class 2, which is more about controlling how the recipient's own immune cells process and respond to the donor antigen. So the author presents this as a complementary strategy, non-competitor strategy, different checkpoints in the same rejection pathway.
I see. And how does it compare with the engineered CAR-Treg approaches that are also in development?
That's another good point. So the CAR-Tregs are built to target one specific antigen and concentrate suppression right where it's needed. Early signals are encouraging, but peer-reviewing efficacy data in transplantation still don't exist, and manufacturing complexity and costs are really limiting barriers. So CD8 Tregs take a different, perhaps simpler route. leaning on naturally occurring regulatory population rather than engineering one from scratch. Both approaches independently are chasing the same goal from different directions too.
Like the Holy Grail, finding the transplantation tolerance. Yeah. So what should clinicians take from this today? What can we learn here?
Actually, I think genuine optimism, tempered by faith. This is the kind of study that tell us whether a cell product can be made and given safely. It can't yet tell us whether it's induced durable tolerance or improves outcome. That's still years and several trial phases away, and so we need to wait longer before saying that.
Patience. So I get it. So stepping back, why does this particular trial matters for the field as a whole?
I think because this represents transplant immunology reaching for tools that have already reshaped oncology and more recently autoimmune disease. So engineered and naturally occurring cell therapy used to steer the immune system rather than blank suppress it. The long-standing goal here is operational tolerance. So a graft that survives with minimal or no chronic immune suppression. We are clearly not close to that yet, but every well-run early phase trial, CD4 or CD8, engineered or natural, adds a small piece to that puzzle.
Completely agree. Also, every cell therapy that has no safety concerns would decrease the burden of immunosuppression for the patients. And the cost and complexity of cell therapy, does that concern us? You already mentioned that CD8 Tregs are maybe easier than the CAR T cells.
Yeah, so it's a real constraint worth naming honestly. These are complex, individualized products, and the experience with CAR T in oncology shows that even transformative cell therapies can take years to become logistically and also financially accessible at scale. Scalability is one of normal problems in cell therapy. So the scientific promise here is genuine, but so is the practical challenge of either delivering these broadly across transplant programs another point.
Yeah, that's a good point. And are there any parallels worth drawing to fields outside transplant? You already mentioned oncology, autoimmune diseases.
Yeah, definitely. The commentary itself points to regulatory T-cell program advancing in oncology, adjunct setting like graft versus host disease, and in autoimmune conditions such as rheumatoid arthritis, with encouraging early results. That cross-pollination matters, lesson on manufacturing, dosing, and durability learned in those settings will likely shape how CD8 Tregs trials in transplantation are designed next. So it's a good example of transplant immunology benefiting from momentum built elsewhere in cell therapy. I would suggest also, for example, diabetes too, for example.
Mm-hmm. Okay, so that sounds really promising. So for today, pulling it all together, what connects these three papers?
Yeah, this was a very good exercise, I think. So precision, for example, at every stage of the transplantation journey, for example, before transplant, thinking harder about who a risk marker like tumor volume actually predicts for example, and during and after, recognizing that antibodies aren't an uniform trait, their molecular fine print matters. And looking ahead, moving in immune suppression from broad and systemic towards the targeted and local. So the shared caution across all three, none of these is ready to change practice tomorrow. Each is a well-designed early signal that needs to be a bigger, harder, and tested before moving forward.
That's a great note to end on. But I would also say that also not like those manuscripts, they don't change clinical routine, but they all tell us there is no one-fits-all approach, especially for transplantation medicine, but more precision and individualized therapy. This is the way to go. So the three papers are available now, open access in Transplant International. Thanks for listening, and subscribe to our future episodes. Thank you.
Thank you, Nina.